Okay,
And
we're recording.
Sorry, how do I advance the slides, or do I just say next slide, or?
Press and resume.
Okay.
So, Brent, I just say next slide?
Sure.
Good morning, everyone, and welcome to our first Fireside chat on implementing a disaster drill at your institution. There have been many of the PRQC participants who've been interested in improving their pediatric disaster preparedness. So we are excited to have you join us today. Our presenters today are Dr. Rita Chung and Dr. Brent Kasny, both who serve as co-directors of the EMSC Innovation and Improvement Center in charge of the disaster preparedness domain. Dr. Rita Chung is an assistant professor of emergency medicine at Harvard School of Medicine. She is also on staff at the Children's Hospital of Boston, where she serves as the medical director of disaster preparedness. She is also the chair of EMSC committee in the state of Massachusetts at the Department of Public Health. So she's been a true friend of EMSC for a very long time. She's also written numerous papers on children in disaster and was a previous EMSC targeted issue grantee where she implemented a model for disaster, family, and child reunification. She, in partnership with our next speaker, Brent, will be discussing pediatric disaster drills. Dr. Brent Kasny, our second speaker, is an assistant professor of pediatric emergency medicine at Baylor College of Medicine and is a pediatric emergency medicine physician at Texas Children's Hospital. He has published and given numerous presentations on pediatric disaster preparedness, and as mentioned earlier, he is a co-lead for the domain of disaster preparedness and recovery here at the EIIC. So at this time, welcome everyone, and I'm going to turn the presentation over to Dr. Chung.
Great, thank you so much for the introductions, and thank you for everybody participating on the call. We're very excited to talk to you virtually, but hopefully in the future meet with you. We're excited that this is one of the domains, the disaster domain, and we understand that this domain may be a little bit more challenging, but we are here to help you, and we're here to help you think about how we can improve disaster preparedness in the hospital setting. Next slide. So this chat is focused on really exercises and what is an exercise, and really in the hospital setting, we probably do this a lot in the medical domain, but really thinking about now more of a systems level. So really focusing on testing a new plan or protocol or procedure. Previous exercises can focus on practicing skills, preparing for more complex events such as mass casualty events, training on new equipment, or assessing and improving ways in which, especially in this bundle, to really how we can work together in various situations. Next slide. And for the group, I think we know that children may need specialized resources or will need specialized resources based on many of their differences as listed here. Next slide. In the disaster domain, I think what we have seen with no-notice events is that pediatric patients can present everywhere, and they may present initially. Once there's an event that happens, they'll present to the closest hospital that may not be used to taking care of kids. And so we want to make sure that all hospitals are prepared for such an event. And part of this strategy is really to conduct exercises that focus on the pediatric populations, or making sure that your hospitals have thought about how you would be able to take care of children in disaster. And there's some specific issues such as treating children who arrive without a parent or caregiver. You may need extra support just to make sure that the children are safe. identifying and reunifying children with their families. In a no-notice event, families go to the nearest hospitals to try to find their children, and they expect you to know immediately. Pediatric triage, how do we train your facility who may not know the differences in the different vital signs of children as they age, and what is when they're sick, what is when they're about to be sick, and what is when they're well. So pediatric triage, utilizing pediatric size equipment, and then lastly, but really very important, is addressing disaster mental health problems. And how do we, in the moment of disaster when things can be overwhelming, help provide a calm and reassuring environment so that we actually reduce the mental health for that child and for his or her future life. Next slide. And really what we hope as a goal is that all disaster-related exercises should include a component or subset of pediatric victims based on their representation in the population and the likelihood of being affected by a mass casualty event. You have to look in your where you are, and if there's a school right by you, then there's a chance if there's something wrong with the school that the children would come to your hospital. So just being mindful of, in the community, what are your potential risks. Next slide. And so in our disaster bundle, we do have some exercises that are to think about. There's pediatric-specific exercises that can incorporate the pediatric population. It could just be pediatric-specific, where you have a school bus accident. It could be family-centered if it was a large gathering, such as a state fair. And then just in general population, children are about 25% of the U.S. population and can represent 25% of the victims. Next slide. And so this is the exercise cycle. This will be on the next 3 slides, but just kind of a framework to kind of think about how you want to approach an exercise or a disaster exercise at your facility. So what we would really recommend is having a multidisciplinary group. So we think if you want to first concentrate it in the emergency room, then it's the medical staff, it's really also the admin staff, and also the emergency management leadership at your hospital to determine what are your goals for the exercise, establish a timeline that makes sense, that you can really craft out what are your objectives for the exercise, and then identify the different types of exercises that you may want to consider for your staff. And we will be talking about that in more detail. Next slide. Next, after you've developed your objectives, you really then can think about the scenario, and we are here to help you. Actually, if you want to craft your own scenario, we are here to help you think about scenarios that may make more sense for your hospital, and then to really, with this scenario, kind of review, discuss, and finalize the scenario. There's like criteria that you feel are most specific to the scenario development. From that, you will prepare briefing materials and then first conduct exercise briefings and then the exercise. Next slide. What's most important after an exercise is the feedback and how you improve. So right after the exercise, we recommend conducting a hot wash, which is really just getting all those who participated to reflect upon the experience that they just had, understand there's a feelings component to it, but there's also a analysis component, what could have gone better, what went really well, and then to take that hot wash and to turn it into a more objectified, what did we learn as a whole. After action reports are helpful in that way to say what are the next steps, how we can improve, so that we can have another improvement plan and then have another exercise. While this sequence is 3 slides, it actually becomes very intuitive, and I would say that we do monthly small 5 to 10 minute mass casualty drills in our emergency room, and we have learned a lot and have actually changed our plans and our procedures based on these, which you can have mini drills in order to have more people participate and understand and be able to give you feedback. Next slide. And so concentrating on the emergency department, I'm going to turn it over to Brent after this, is we really think about the 4 S's. If you are part of a flow committee or capacity committee, you probably already think in this way also, but it's really staff, stuff, space, and structure. So staff, if we needed more staff, how do we get more staff? Stuff, if we needed more equipment, pediatric equipment, what is the mechanism to do that, or where do we have the stuff? Space, how do we utilize the spaces that we have? If we have a lot of children coming in that come in from a disaster but actually are pretty well, what space can we use that will not be the emergency department, that will allow them to have a safe space, but also be supervised? And structure, what kind of command structure that you can feed into that is already at your hospital. So I'm going to turn it over to Brent.
So I think, thanks, Rita. So I think moving forward, we're going to talk about the different types of exercises that you can do and how to build from that. I think something that's important to recognize when you're doing this in the hospital environment in general is that there can oftentimes be, I think those of us that are clinicians are used to working in simulation and other types of scenarios and situations where we recognize that the activities and the responses are really, non-punitive, and we're trying to learn from these events. And I think one of the things that I've recognized just kind of as an intro to this part is that sometimes it's viewed by the administration or by hospital leadership that, you don't want to show failure. And that's really kind of a failure of the system in general, because what we're trying to do is recognize where the failures arise within the system so that we can make improvements. And so I think on the outset, just identifying that this is all for learning's sake and that no one's going to be, no one's going to be reflected upon poorly as a result of any of the outcomes of any of this is really important to just start that and make sure that this is recognized as like a safe space for learning for the institution and for those that are participating. But there's a variety of different types of drills that you can do, and we're going to kind of build towards the big kind of monster full-scale functional exercise. But I think recognizing the importance of all these different types of drills and types of exercises that you can do is really important because while the full scale is kind of the thing that everyone thinks about as kind of this big thing to shoot for, I can tell you from personal experience, it's not always the thing where you learn the most from. And oftentimes, even as Rita was mentioning, these really small snippet 5 to 10 minute drills can be very helpful and very informative for your group to learn from. The first types of drills that we're going to talk about are discussion-based exercises, which are things like seminars, workshops, tabletops, and games. And these are really, as kind of the title, explains, they're really supposed to lead to a discussion and lead to a conversation about what the challenges are and then how to overcome those challenges. Oops, I went too far. Sorry, can I go back 2 slides? I apologize, Crystal.
Use your keyboard and hit the up arrow.
Oh, sorry.
There you go.
So starting, we would start with seminars. And seminars are really just to orient participants to what the plans and policies currently in place are. So these are really kind of almost more didactic in nature, but they're really orienting everybody that would be involved in any future drills as to what the current plans are, what the current policies and protocols are. But they can also be very helpful in just getting feedback from individuals as you talk through what the current plans and policies are. So while this doesn't really necessarily have to have a scenario in place when you're thinking about this. It's more of a meeting where you're talking about what the current state of things are and what we're going to work towards trying to improve. And having those things in place, I think, is really, really important, and recognizing that this conversation and multidisciplinary approach to this is really important, as Rita mentioned too, to have all those kind of participants that would be engaged in a real event at the table. And so this is a good way, I think, to get those people at the table and to recognize, kind of get some common ground among everybody as to what the institution has in place. The next thing would be workshops. And these are things, this is a drill where we're really going to have much more participant interaction. It's kind of like a tabletop light, where you're looking at some of the plans and policies, identifying where maybe some of the weaknesses might be, and trying to enact changes in those, but really in a much more interactive manner. Further discussion-based drills could be tabletops, and I think these are things that we kind of say, sometimes while they don't have volunteers and the moulage and things like that, they can be extremely helpful in generating discussion. And these photographs that you're seeing here are actually from a recent radiology-focused mass casualty drill that we did at Texas Children's, where we were really looking specifically at things like, what the throughput for radiology is in a mass casualty event. So on the slide, you can see that we've got patient cards that are the yellow and red cards. Those are outlining patients. And then you can see kind of a bunch of different cutouts that signify physicians, nurses, respiratory therapists, radiology techs, and then a timer that's kind of counting down in a kind of a shortened time frame, kind of scaled time frame, how many minutes it takes to get a portable chest x-ray done, a CAT scan done, and going through the motions of what that would look like in kind of an artificial environment, but recognizing where bottlenecks can be present, and then identifying how to change those bottlenecks to improve workflow. So these are things that you can run through very quickly once you've set it up. And again, like Rita mentioned with the small drills that they've done, the quick drills that they've done, you can do this multiple times with different people to get different viewpoints and different input. Next, for discussion-based drills would be games like simulations, and here's a screenshot from 60 Seconds to Survival, which is a disaster triage game that is linked to on the EIAC's webpage, that walks the user through a mass casualty scenario where they're applying jumpstart triage. So again, recognizing that it serves a specific purpose of teaching field triage systems, things like this can be really useful if they have a specific purpose and aim that they're working towards. Moving past discussion-based, we look at operation-based, and this tends to be what we think about the most when we think about disaster drills. And these are drills, functional exercises, and full-scale exercises. And sometimes the line between these three get kind of blurred as we do them in a practical setting. But I think, again, one of the important things to think about when you're looking at this is going back to that the exercise cycle that Rita had mentioned earlier, and how it's extremely important to, at the onset, really identify what your goals and objectives are for these operation-based drills. And I'll show you some examples that we've had, and also kind of talk through some of the challenges that we face doing these, so to hopefully prevent other groups from hitting the same roadblocks and challenges that we've faced doing drills here at Texas Children's and other institutions where I've participated in drills. So an operation-based drill is really testing a specific operation. So you're looking at something very specific that you're looking at trying to test. This is just really one procedure or plan that's being exercised to see how it's going to work in the grand scheme of things. And it's important, I think, that it's kind of limited in its focus to that specific plan or policy. And so as such, it's kind of, going to look at that specific plan or policy and try to focus on it. And so again, these are things that, again, have probably more moving parts involved than the tabletop, but trying to see what the real world hiccups will be when you're working through some of these. Functional exercises are really validating and evaluating those plans. So you've created these plans and you've hopefully talked them through with some of these discussion-based exercises through the seminars, the workshops, the tabletops, and maybe done a drill or two, and now you're really looking, kind of putting boots on the ground and trying to see how this looks when it's really worked out in real life. So for this, I've got a little floor plan that we created at Texas Children's for a radiation injury treatment network functional exercise that we did in the middle of last year. And what you can see is we really sat down and created a policy and a plan, and we said, okay, this is what we're going to do if our reception center after a large-scale radiologic event. We're going to use these conference rooms. We're going to do this. And so we created this plan. We put a lot of thought into it through doing some workshops and seminars, but we really wanted to see what it looked like when we actually did it, and then we did, and this is the functional exercise that we participated in and ran through here at Texas Children's, where we set up all of those parts that we had kind of put on paper to see what it looked like. And you quickly recognize where you look at this beautiful floor plan that we'd created, and you see all these, okay, we're going to have tables here, and we're going to have curtains here. And then you get into the space that you think is going to be the perfect space for this. And we were kind of tripping over each other because we had so many people crammed into this very large conference room. And that's when I think you recognize some of the challenges that you face. And it's very helpful, I think, moving forward to get a better feel for what things are going to look like should this happen in a real event. And then again, you go through that exercise cycle, and much like a PDSA cycle or quality improvement cycle, you're going to say what worked and what didn't work. And that's really the goal of these types of exercises and drills, is to improve the plans and policies that may look great on paper, but when you kind of run through them, things just don't work like they normally do. And we're fortunate enough, I think, in healthcare that we're used to doing this in clinical operations, frequently. So we kind of say, okay, we're going to have this new plan for treating asthmatics. And we see tons of asthmatics, and so we're able to work through it and recognize what the problems are. The difficulty comes in these kind of very, rare events that, hopefully occur infrequently in your community, where you're not going to be testing this on a daily basis or multiple times a day. This is going to be hopefully something that if it happens ever, it's going to happen once and never again at your facility, but you want to be prepared should it happen. And then building from the functional exercise, you talk about the full-scale exercise. And this is kind of the big drill that we think of, I think, the most commonly when we think of these drills. A lot of things what we think about are these full-scale exercises. And these are obviously the most complex. They're extremely resource-intensive. And they can take a lot of time to plan and a lot of work to do. But that doesn't mean that they're necessarily, I think, the best for the sake of what we're looking at for the disaster bundle, disaster arm of the PRQC, in that, as I mentioned, they are extremely labor intensive. They require a lot of work to get up and running. The photograph that you see here is from a full-scale exercise that we did at Texas Children that involved Houston Fire Department and multiple law enforcement agencies responding to an active shooter event at a large high school. We had over 400 high school students participating in the drill at their school. 50 of those students in full moulage were then transported and simulated arrival via EMS at our facility. And, not to scare you away from doing one of these, but it took me 2 years to plan this drill and to get it off the ground and running. And in the end, I think we probably have learned more from some of the smaller tabletop exercises that we've done than this. Now, it was great to do, and I think we did learn a lot from it as an institution, but I think it's just important to note that you really, I can't highlight enough the importance of some of these much smaller scale drills that are much easier to pull off, but you can really get a lot of great information from. So here's the video of that kind of exercise in place. And you can see there's a lot of moving parts, a lot of people involved, a lot of mock victims, physicians, et cetera, leadership from the hospital working, full command center working to participate in that drill and make it happen and make it work. And that doesn't necessarily lead, sometimes it's a little bit kind of the old adage of too many cooks in the kitchen, to great and useful output moving forward. And so I think it's, again, important to just stress how beneficial some of these smaller drills can be. This is just kind of a summary table, and I think we forgot to mention at the beginning of this, a lot of this content was taken from the Topical Collections at the AAP's Children in Disaster website, which we wanted to highlight as a terrific resource that's been recently made available online. But this compares the various types of exercises that we just reviewed: seminars, workshop, tabletop, games, drills, functional exercise, and full scale, and can show you kind of how long these things take to plan, who needs to be involved in the planning, et cetera, and what some of the output will be ultimately in the end. So, moving forward, where do you go from that? I think after the drill, especially when you do something like that large-scale, full-scale functional exercise that I just showed some pictures from, at the end, you're kind of just so relieved as the team putting this exercise and this drill on that you've completed it and gotten it done, that it's really easy to kind of just pat yourself on the back and be like, yay, we did it. We finished the drill. We got this done. And everyone kind of high fives, and then you just, breathe a big sigh of relief that you got it done, and don't do the most important part, which is that kind of final slide from Rita's of the exercise cycle, which is really having that valuable information from the hot wash, the creation of the after action report, et cetera. So really afterwards, you want to revise that plan, take a look at all the information that you gathered, revise the plan, and figure out what changes you really need to make. And move forward looking at what the next step is going to be in testing those revisions that you've implemented as a result of that plan. As mentioned, a lot of the content from this talk was taken from the AAP's Pediatric Disaster Preparedness and Response Topical Collection Pediatric Preparedness Exercises chapter, and there's a link to it here. And the full content is available online at the AAP's website for children and disasters. And it has a lot of information that's very broad-ranging, but there is an entire chapter devoted specifically to conducting drills. And I think it will be very useful and helpful to anybody that's working down the PRQC's disaster bundle, because a lot of this information is going to really be helpful to conducting, drills that are going to involve as many people that you can possibly involve without stressing the system from a resource standpoint to get it done, but reaching as many people as possible to then get their input to hopefully improve things for the future.
Thanks, Brent. So what I'm going to do now is take control of the keyboard and mouse, and I'm going to unmute some of our subject matter experts that are on the call today. Oscar, I can see that you are on the call, but your phone isn't connected, so we won't be able to unmute you, but feel free to provide some feedback through the chat box. Pat, I'm going to go ahead and unmute you as well. Ariel, you are unmuted. And Diana, is there anyone else that you'd like to unmute at this time?
No, unfortunately, I'm guessing that Dr. Krug got tied up because as he was planning on being here as well. So, but we're fortunate to have, 5 subject matter experts available to our participants if they would like to ask questions at this particular time. But perhaps while we're waiting for questions from the group, we let our subject matter experts who took the time to join us chime in if they have additional content that they would like to share.
And I would also just like to add before that we're available at the EIIC. I recognize the challenges and kind of some of the growing pains that can take place when you're trying to get these things up and running at your institution. And, I'm available, very readily available to help out in any way that I can, and Rita as well, to make you guys successful in this endeavor.
Hi, this is Pat Frost. How are you guys today? I want to echo what Brent and Rita have been talking about, and I really am an advocate of baby steps in terms of this process. It just makes The small bite of the elephant makes the progress continue and doesn't make it so overwhelming. One of the things that I would encourage people to do is make friends with your emergency managers in your hospitals. Part of what I keep on seeing in the community is that people don't know what the other is doing. And so just by having a conversation, you may tap into resources or opportunities to go ahead and do that. The other thing is as a champion for pediatrics, you can then begin the incremental education process to make children more approachable so that they're more willing to integrate children into their exercises, or that you may find opportunities to partner with them in a manageable way. And I think Brent laid out a whole repertoire of different ways to do that, which are just terrific.
So what I'm going to do right now is unmute all of the callers. We have several teams, Rita and Brent, that are on the line. And so everyone at this point, you're unmuted. Feel free to ask any of our subject matter experts any questions you might have about the content today or how to actually operationalize this disaster bundle.
This is Oscar. Can you hear me?
Yes, I can.
So I wanted to add on to that. That was a great presentation. All the information is great. One of the things that I would like to add is anytime that there's a drill, whether it's tabletop, if all the work is being done for a simulation, if everybody can take advantage of anytime you do a drill to plan it as realistic as possible and try to steer away from, in the real world we would do this, make it as realistic as possible. That way all that work that's being planned is for a real event, not for in a real world. And the other thing is, if anytime there's a real event that just occurred, for example, Joplin tornado, Las Vegas shooting, and so forth, if you take advantage and tap into their after action report and take the information that they learned and plug it into your emergency plan, that way you're already a step ahead with your plan. And anytime that you do your drills, for instance, your scenarios, focus on your vulnerabilities for your area and plan on those scenarios.
Yeah, Oscar brings up a really good point, and people and the whole community and the organization will always be more open to including children into exercises as well that they are preparing for, just as part of their normal Joint Commission or state requirements. When a real world event has happened, it creates an urgency in the community to say, and people start asking, what if that happened here? What would we do? And that's a perfect opportunity, and people are more open to including children during that time. So thanks for those recommendations, Oscar. They're great.
And to echo, it's Brent again, to echo what Pat mentioned, I think it's important. What we oftentimes see is an event occurs in the community, and there's this sense of urgency to do a drill that's somewhat reactionary to that event, but not really focused looking at that exercise cycle to make sure that the planning steps have been in place ahead of time to make sure you're going to get everything that you can from that event or from that drill.
And so now, Rita, I just wanted to just echo a little bit what Oscar said. Also, what we have found is initially to introduce the concept, we have had done many tabletops at our institution, but really now focusing on actually having our drills, specifically those in the emergency room, based in the emergency room, so using the staff that are actually on that day and practicing in a mini drill, I think allows people to have more muscle memory, but also takes away, well, in the real world, because we were actually practicing on our ED floor.
Thanks for that. I noticed we have a couple teams that are on the line. Any specific questions for our subject matter experts? I see we have Georgia Peaches on the line. There's someone from possibly Mocan Rocks or the Lifesavers.
This is Peggy from Georgia Peaches. The links that are up here with the AAP are not working.
Okay. Let's try something.
I can add a link. Into the chat box right now.
Okay.
To the Topical Collections. Give me 1 second.
I'd like to hear from, where people are in their teams right now. What do you think how are you guys doing with all this stuff?
Speaking here, this is again Georgia Peaches. We do drills, and we're able to do drills, but we don't have the policies or anything or best practices to build on.
And when you say best practices and stuff, are you including children in those drills right now?
Yes.
And then in terms of best practices, is there something specific you want to try and improve?
Well, we don't have, our institution, we don't have policies for the pediatric population that we wanted to do. We wanted to address the, like you said, reassuring, reducing anxiety, reuniting, what is the best practice for reuniting, what do you do with your special needs populations?
So those kinds of things. If the group can, if there's a mechanism to collect, these specific topics, I can look through my materials with the listserv, the National Pediatric Disaster Listserv, and see if, other people have some specific guidance, because there's a lot of materials available, and I think, we could probably provide that to the collaborative and, help you with some of that stuff.
Okay, thank you.
This is Rita. Thank you. Please let us know what you feel like you need. I think the AAP recently released family reunification practices for healthcare facilities, and so that has some of what we did a 2-year-long kind of research with the subject matter expertise to try to figure out what would make the most sense, and so there are some things there. I do think we do have some on the EIIC website, but if there are any specific ones, we are very happy to help you think through that, or think through your pediatric safe area. What kind of things would you need? The people that you think that may be at the hospital that could help assist with mental health needs. I think we will have to have different models based on different size hospitals and just the needs of the hospitals.
Yeah, and I do have, this is Pat again, I do have some examples of policies and steps, but I really need to know exactly what you're looking for so I can send you the right materials.
So from the Georgia Peaches team, can you respond to Cassidy Penn in the chat with your name and email address, and we'll get you paired with the SMEs.
Okay, thank you.
And a lot of these resources are referenced in the disaster bundle itself, in the large PDF part of the disaster bundle. But I did put a link in the chat box to what Rita was mentioning, the AAP Reunification Toolkit as well, so you can access that. because I think that's a great resource. We at Texas Children's, we recently just revamped our entire reunification plan and policy and used it and found it extremely helpful. And I'm hoping once it's been totally finalized, I'll be able to share it with the group as well.
So, Brent, I've got a question for you. I know we've got about 20 minutes, or open to any of the SMEs, about are there any hard, fast rules about how frequently we should be having exercise or drills?
Well, you're asking the people that think this is like what we love to do. So it's always a little bit of a loaded question. I mean, I think that if you can institute a situation where you're doing like what they're doing in Boston and what we are aiming to do in Houston as well, which is do something that's very kind of low as far as using resources, but high as far as getting as many people involved and engaged. So doing something monthly, but it doesn't take a lot of time. That's great. And then shooting for, as Joint Commission requirements and CMS requirements requiring annual exercises, those are great times to jump onto the kind of hospital's need to conduct these things and do something larger scale at least once a year. I think is a great goal to shoot for.
Yeah, Brent.
Oscar may want to speak up as well, because I think he's actually doing monthly, and he's found a unique way of doing it. So he may want to share his experiences as well.
So one of the things that we do is I stress out that emergency management, so to speak, it's a living, breathing beast. It's constantly changing. You have to stay on top of it. One of the things that we do is we do train 3 times a year. We have hospital emergency response teams. They're HERT teams. The training that we do, not to get anybody overwhelmed, but our training that we do is separate from our quarterly required trainings, from the Joint Commission trainings. And we train on scenarios. Like, for instance, our upcoming training in March, in April, it's our tornado season. So we create scenarios and we do alternate care sites. The day that we train, the team does not know what the scenario is going to be, and on that same day, I say, okay, this is what took place. A tornado hit our ER. Go set up an alternate care site, and then we're on the go. It's realistic scenarios. The thing when you do scenarios, just to when people are working on their drills, if you dissect a drill, and there's a lot of components, but when you do an after action, and if it's a bad simulation, you're doing a lot of work off of a bad simulation that's never going to occur. So when you do your drills and you're planning, the more realistic that you can do it, the better, because all that work that you're putting into it is going to be for a real event. Now, the other thing is, you may hear all the time, oh, we're working on our drill for this date. Well, you should work on the drill if it happens like right now. So there is a lot of work that needs to be done in between training and in between drills. And that's where the majority of the work is throughout the year, day in, day out.
I think to add to what Oscar has mentioned, conducting a hazard vulnerability analysis is also a requirement for institutions. So emergency management at your facility should be conducting some sort of hazard vulnerability analysis that's going to show what those actual vulnerabilities and risks are for your institution. And I think what we've really realized is that, these are the scenarios and these are the things, especially those, like Oscar mentioned during tornado season, at their institution, these are the things that kind of are keeping the high-level administrators up at night, right? These are the things that when they're the administrator on call or whatever the structure is at your institution, they're the ones that would get the call and need to come to the command center and work on these things. they're nervous about getting that call and having to respond in these events. And so reaching out, I think, to the institution and recognizing that there are people that are really interested in this information and how to get it disseminated on a kind of widespread manner to people in administration is important as well. And I think it has been mentioned many times throughout the course of the 45 minutes we've been on the webinar. I think this really needs to be a multidisciplinary approach. And unfortunately, oftentimes emergency management is kind of working in their own little world and not reaching out to a lot of people throughout the institution. And we recognize that getting as many people interested in hearing what they're working on has been extremely successful in us getting buy-in from the hospital and from the institution.
One of the things, this is Pat, one of the things that I found in my own community is that when we did an assessment, we found that if all the hospitals received 5 critical kids at the same time, it was going to overwhelm the system. So we have 8 hospitals, and it wouldn't overwhelm them for a long time, but it would overwhelm them if they all came in at the same time. So from a practical standpoint, what we recommended was that each hospital begin with 5 critical kids in their exercises. And this may be especially helpful for hospitals who don't feel that they don't have the policies and procedures in place, because having those critical kids, whether they're trauma or bus accident or active shooter, will begin to help you identify what policies and procedures and what gaps you have in your current system. And then as you get more expert at and this would be a great analogy just to do as a tabletop. You don't have to do a full-scale drill. You would be able to identify where your gaps are. And then as you get better at this, you can scale it up to a more complex exercise. But you have to start where you guys are and not try and, leap tall buildings at a single bound, So because you can get really discouraged, and people can get really discouraged, with this. And this is what's worked for us in our community and helped people embrace, and reliably include children all the time.
Any other questions from our affiliate sites? So I have another question for the SMEs. You've shared that generally children make up 25% of the disaster victims. Would you advise that when planning a local drill, we plan on having at least a quarter of our drill victims be children?
I think, sorry, it's Brent. I think that's a great kind of starting point for these exercises, is to look at your region's population and identify what percentage are pediatric. And so that's an easy way, I think, to team with drills that are currently underway and include kids. But then I think doing the kind of scary drills, especially for non-pediatric specific facilities like the bus accident where it's all kids, those are important things to think about too, because those are the things that I think we're really, especially non-pediatric facilities are really kind of, that would definitely put them out of their comfort zone. But I think starting just with having them be whatever that population percentage is a great starting point.
And this is Rita. I think that I agree with Brent. It's a great starting point. I think it really is what your hospital needs are. And so if you would like to try to practice a pediatric safe area versus thinking about how you want to reunify children, but also just reunify families, you can do specific ones. I can tell you that we did a drill where we did a reunification drill, and we developed this really nice pediatric safe area. our child life had go bags, we had video games, we had crafts, we had a movie in the background, a lot of planning that went into it. And then we found out that when we actually got 20 to 30 kids in that space, it was much too small, and the babies hated it. And so it would just encourage you to have children in a very safe way, have children participate in drills, and you'll learn a lot. We thought we knew everything. I can't believe I'm saying that, but we actually, once we got into this space, we were like, this is, there are better ways to do this, and now our plans are much better for doing it. So I would just encourage having children in your drills to really we think we know what they're going to be like, but we actually don't until we actually drill it.
So, Brent, I know that you spend a lot of time working on these workflows. We have a couple questions from our participants about how do they really get started from step one. If they are new to disaster planning, and so I pulled up one of your workflows, but do you mind in these last sort of 8 minutes to walk us through what you think would be the best first step, and does that include these workflows that you have in your resource kit?
Yeah, sure. Is there any way you can zoom in on them a bit? Because that's great. Okay. So I actually think that the first diamond is the most important diamond for the disaster bundle, which is really the nuts and bolts of it all, which is going to be, do you know who is working on this at your institution? There is someone. They might have 18 other jobs or 6 other hospitals that they're covering in addition to your hospital, but it's really going to be key to your success working through the disaster bundle that you identify who that person is. And, I think Pat was the one that said this, you got to make friends with these people because they are going to be key, I think, to your success in working through the bundle. I actually think that if I was new to Texas Children's and working through this, I could get a lot of the way through this first workflow just by having a really good sit-down conversation over the course of an hour over coffee with my emergency management team at Texas Children's. Now, I'm fortunate we have a very robust team that does a lot of work, but just knowing who that person is going to be key. And if you move down this workflow from finding out who that emergency management person is, you're going to be able to, by just talking to them, and if you can slide down this workflow a bit, you're going to be able to answer a lot of these questions on this first page. So really, you'll be able to, just by having them answer a couple of questions, get all the way down to structural measure 1C, which is who's kind of the pediatric point person that's engaged in emergency management, if there is one. And if there isn't one, then the goal is to include somebody like that in the planning process in some way, shape, or form. And they're going to have copies of the disaster policy or plan for your institution. Now, whether or not that's a very usable document is really up in the air. I think when I think back to the earlier in my time at Texas Children's, we had a hospital disaster policy plan. It was throughout the hospital and red binders everywhere, and it was completely, worthless might be too strong of a word, but it was really an unusable document. It was not something which is its intent is that you can take it off the wall, open it, and figure out what to do, and it was not that. It had a lot of information, but not a lot of useful information. And so I think that's step one, and that'll get you to this kind of green box below pediatric contact info is just talking to the emergency manager. And really moving further down this workflow for the first page of this, a lot of these things are going to be just having conversations with that emergency manager. In fact, all of these things they should be able to answer when they talk about past drills that they've done as part of their Joint Commission requirements. Have they had kids in drills? how many kids have they done in these drills, et cetera. So you're really going to be able to get very far down on this, I think, just by having that really, robust conversation with emergency management at your facility.
Okay, Brent. So what I'd like to do, since we do have just a couple more minutes, is to show our users what data components that we're asking for in the data portal. So we do start with some site-level data, asking specific questions about whether you have a disaster plan in place, when was it established, and then what domains are currently described in that plan. We ask the number of pediatric patients that are involved in your drill to give us that value, and then, as Brent mentioned earlier, some of the key components of that workflow. So is there a pediatric representative? Are you part of a regional disaster coalition? And then do you have a list of those sort of entities that participate in that regional activity? We'll get more detailed information about what you currently have available related to surge capacity, and then you'll move to the drill level data. And here you'll have the option to do 1 to 10 drills. We don't expect you to make it all the way to 10, but you'll have the opportunity to enter data for all of those. We'll ask a date for that exercise, and then your drills will be related to 3 domains. So that will be coalition building, surge capacity, and then essential resources. All of this content is typically based with timestamps, when departments are mobilized, and then which member of the care team is available, what beds and resources are available. What we like to do is remind you to go on your website, and you will see a paper version of this document that you can start looking over with your team in case you'd like to do some pre-work. And what we'll do is follow up with all of the members that have said that they are going to do the disaster bundle to see if they need any direct help with our SMEs. Kate, Diana, any last words before we end today's call?
I think I'd just add, sometimes this, we've talked a lot about the details of disaster planning, and just to reiterate that taking baby steps, just taking it one piece at a time, because thinking about it, globally can be a little bit overwhelming. So I know that was stated by our subject matter experts earlier, and just to reiterate that. And just thanks so much to Rita, Brent, Pat, Oscar, and others on the call for joining us today. Diana, I don't know if you have anything else to add.
No, just a special thank you, and I totally agree with the baby steps. I happened to work with the EMSC program when they were gathering a checklist for pediatric disaster preparedness and things that people needed to consider. That checklist is on the website as a resource, but I would strongly encourage you to not look at it until you've taken some of your initial baby steps and looked at the workflow that Brent outlined for you all, because it is so comprehensive. I could see it becoming very overwhelming, and yet at the same standpoint, it has a lot of helpful information in it if you're looking for more specifics regarding the specific considerations that you all need to be taking. But thank you, Brent, Sarita, Pat, Oscar, and Ariel, all for joining us today, because I think it's been really great to have you all here sharing your expertise in that area. And thank you to our participants.
Thanks, everyone. And the next Fireside chat will be weighed in kilograms on February 19th at 12 p.m. Central. Thanks for joining, and we'll talk to you soon.
Thank you.
Thank you.
Thanks, everybody.